Welcome everyone to this evening's webinar, Biodentine, One Material, Many Possibilities. Before we begin, I'd like to extend my sincere apologies for the late change in timing. Thank you for your patience and flexibility. It's truly appreciated. It's now my great pleasure to introduce our speaker for tonight, Dr. Mitra Elli, a highly respected expert in endodontics whose dedication to clinical excellence and education has made a lasting impact in the field. Dr. Elli earned her DDS degree in the year 2000 in Iran, and her passion for endodontics led her to complete a rigorous 3-year specialty training program at the University of Shahid in Tehran. Since graduating in 2003, she has practiced as a board-certified specialist endodontist and served as an associate professor at the University of Zahedan for 3 years. In 2009, Dr. Elli relocated to the UK with her family, where she successfully passed the overseas registration exams and became registered with the UK General Dental Council. She has since focused exclusively on endodontics, accepting referrals for all complexities and delivering comprehensive solutions for challenging cases. Literally just today, Mitra received news that she has become a member in endodontics of the Royal College of Surgeons of England. So huge congratulations for that. Her commitment to education is reflected in her roles as clinical tutor for postgraduate students at the University Dental Hospital of Manchester and associate lecturer at the University of Central Lancashire. She has lectured nationally and internationally on a wide range of endodontic topics and is currently finalising her application for the GDC specialist list. Dr. Elli is also an active member of several professional organisations, including the British Endodontic Society, the European Society of Endodontics, and American Association of Endodontics, and the Northwest Endodontic Study Club. We are truly honoured to have her with us today to explore the many possibilities of biodentine in clinical practice. We'll aim to answer questions at the end of the presentation, so please feel free to submit yours as we go in the questions section, which should be located at the top right of your screen. Any questions Mitra is unable to answer immediately, or in the case we run out of time, we will get back to you after the webinar. There is also a poll live in one of the many boxes in the top right corner of your screen, where you can request an in-practice demonstration of Biodentine XP, which will be arranged after the webinar with your local representative. Mitra, over to you.
Well, thank you so much, Jake, for this lovely introduction, and thank you everyone for being here tonight for the presentation about Biodentine. I just want to say that I'm not advertising Biodentine. It's just a material that I have been using for a long time, quite successfully. And I really like it. I'm really passionate about the possibilities that it offers for us in different clinical scenarios. It's mainly made for, main indication is vital pulp therapy, which we'll touch on in details tonight. But I have personally, and I know that many of my colleagues have used it in different clinical scenarios. So tonight, hopefully, I will be able to share my experience, what I know about it, and hopefully give you something to think about, maybe something that you can apply in your clinic after this webinar, hopefully. So thank you for introduction, Jake. I'm just going to put some pictures onto that introduction. This is me. This is Tabriz, the city that I was born and brought up in, and this is the University of Dental Faculty of University of Tabriz, where I finished my DDS degree. Then I went into a specialty training program in Shahid Beheshti University in Tehran, and this is the Tehran, beautiful city that I used to live for a long time before coming to the UK in 2009. And we settled in Manchester. We love it here. And this is the University Dental Hospital of Manchester, where I work as a clinical tutor 1 day a week. And also I work as an ad hoc associate lecturer in the University of Central Lancashire with my lovely colleague, Dr. Shalini. Then the rest of the week I am at practice, mainly at Endo 61, where I work with my dear colleagues, Dr. Sanjeev Bandari and Dr. Shanil Patel. And then other days I work at Love Teas with my lovely colleague, Dr. Ilana Sudri, at Boutique Dental 23 with Dr. Peter Dory, and 32 Whites with Dr. John Mantle. And this is my family. I live here in Manchester with my husband, 2 boys, and our little dog, Trixie. So this was an amazing, this is like a family, basically. Bio siblings, we called it in Septodont Global Pulp Summit. which was an amazing event thanks to Septodont in January in Paris. And it was a great opportunity for me to hear the lecture of really esteemed speakers, and also I had the opportunity to talk to them. So the things that I knew then was challenged, and it was really amazing. And I will tell you during this webinar that how it changed my view. You will see it in a minute. Right, so overview of the lecture tonight is we are going to talk about Biodentine, a little bit about science. I hope that it's not going to be boring for you, but I really emphasize on the sides of the science that is translatable to clinic. So when I say something about clinical use, you know that it's backed by science, basically. And then we're going to talk about caries. At the moment, there is like a controversy on different aspects of or different opinions about caries removals, selective versus non-selective. I will provide some evidence, some guidelines, some protocols, and then you'll be able to hopefully make your own decision. And then some clinical indications, which, as I said, Biodentine is mainly for vital bulb therapy, which is a very it's going to be the lengthy part of the big part of this presentation is going to be about vital bulb therapy. And as I said, I have used it in different clinical scenarios, such as perforation repair, regenerative endodontic treatment, resorption cases, apical plug, apical surgery, and obturation material. So we're going to be talking about those as well. Okay, so Biodentine is a hydraulic cement developed as a dentin replacement material and specifically targeted for vital bulb therapy, as I mentioned. There was an old version of Biodentine, which was the powder and watered separately. So we had to add water to these capsules and then mix it and then use it. But this new one is already basically the powder and the liquid is already in one capsule. I will show you exactly how to use it, and I will show you that why I like XP a lot better than the previous one. I will actually show you the reason that this new one is much better option to use. So in terms of chemical classification, Biodentine is a hydraulic cement, but hydraulic cements can be divided to hydraulic silicate cement and hydraulic aluminate cements. We're not going to talk about hydraulic aluminate cements. Our target is hydraulic silicate cements. And then they can be hydraulic calcium silicate cements. And those can be Portland cement or calcium silicate cements, and then, which is the base. And then the vehicle can be water or non-water. Sorry, I find this word really hard to pronounce. I had to check on YouTube to see how to pronounce it. I think it's pronounced aqueous. I don't know if I pronounced it right or not, but anyway, I'm going to stick with water, non-water. So Biodentine, because we have the powder separate and liquid separate, so the vehicle is actually water. And we have some modifiers. But keeping that in mind, Biodentine falls into the type 4 material. So it's a tricalcium silicate with a vehicle of water and with modifiers, which makes it type 4. Okay, so let's see what's in the powder. A huge amount of powder, 80% of it is actually tricalcium silicate. And that's really important because this is the biomaterial, this is what we're looking for, and it's a tremendous amount of this powder is actually 80% of it is tricalcium silicate. And then we have the modifiers such as calcium carbonate fillers, which is the 15% of the powder, and it has two main basically roles. It causes higher early release of calcium ions, which is really important because we need that early release of calcium ions for all that biological reasons, and also it acts as a nucleating agent. So when the hydration and the setting is starting to take place, that those byproducts can start to gather around these calcium carbonate fillers, which act as a nucleating agent. And I'll show you a picture shortly. And then there's zirconium oxide as a radiopacifier, which has the 5% of the powder, which consists of the 5% of the powder. and gives the radio opacity of 5 millimeter aluminum thickness. So what is the advantage of using zirconium oxide? You know that in MTA, the radio pacifier is bismuth oxide. Bismuth oxide is not very stable, and in time it changes and causes discoloration, whereas zirconium oxide is a lot more stable material, and so we don't have that disadvantage of discoloration, which we usually get with MTA. Also, it does not interact with the reaction byproduct present in cement matrix, so it acts as an inert filler. Now, what's in the liquid? We have the water, we have calcium chloride, which calcium chloride reduces the setting time, and that's, again, another big advantage of Biodentine over, for example, MTA, is the reduced setting time, and it really helps us with different clinical scenarios. And also hydrosoluble polymer, which is hydrosoluble polymer has dual role. It reduces water powder ratio, so it enhances material strength. And you will see that why it's important, because Biodentine sometimes can be used, I mean, especially in the new protocol, which again I will show you, as a provisional restorative material and permanent dentin replacement material. In that provision, and when I say provisional, we can sometimes leave it for 3 months, 6 months, so we need some material strength, and the role of these hydrosoluble polymers is to give that mechanical strength. Also, it increases material flow and improves material handling. What I like so much about Biodentine, and again in clinical cases, you will see that the flow actually plays an important role, because you just leave the Biodentine in the cavity and it flows nicely into all those nooks and crannies, into those areas. And you really don't need to pack it. You really don't need to manipulate it into getting into those areas, and it flows very nicely. So it improves material handling. So this is a picture of the set material, and this is the chemical reaction. In chemical reaction, tricalcium silicate, when added to water, it turns into calcium silicate hydrate and calcium hydroxide, which is the part that we need for antibacterial activity, for alkaline characteristics, and also for basically stimulating hard tissue or remineralization, hard tissue formation. So in this picture, if you look, these gray areas, these areas are basically calcium silicate hydrate, which is the byproduct of that interaction, of that chemical interaction. And these are the small pieces here are that calcium carbonate, which I told you can work as the nucleating basically area, which then other material can start to basically gather around. And these tiny little bits, white ones, are the zirconium oxide. Don't get bored. We're going to be finishing very soon from this, and then we'll go into clinical stuff, which is more interesting. So as I said, Biodentine can be a provisional coronal restoration and also permanent dentin replacement. Now, about the setting time, one of the good characteristics of Biodentine, as I said, is the setting time, which is a lot shorter than, for example, previous materials. And we have initial setting of about 6.5 to 16 minutes. In this time, which manufacturers is about like 12 minutes. The material is kind of like a plastic workable paste. And then we have the final setting time, which is 45 to 86 minutes, and then it can turn into a rigid solid material. So it was previously said that the working time with Biodentine is about 6 minutes. So you kind of like manipulate it for 6 minutes and then leave it, and then 12 minutes, the initial setting is finished, and then we can leave it. Recently, I personally don't even manipulate it for that 6 minutes, and I try to have like minimum manipulation. And honestly, the characteristics of the material is such that it doesn't need any manipulation. It doesn't need like packing or anything. So I just let that material to do its job, to do the setting, and basically keep its characteristics. And I'll show you that how different it can be, manipulation and not manipulation. And from clinical point of view, so the first one was actually what I've just told you, and the second is that the environment in the mouth can potentially affect that setting time. So if you have inappropriate isolation, if you have contamination with blood, that setting time can increase. Contamination with blood can increase it up to 6 hours. So maybe that's why that some people might be thinking that a Biodentine maybe is not a good material for as a root end filling. I have personally never used it as a root end filling material, or maybe apical plug. I have used it as an apical plug successfully. I'm just thinking that, well, we have used MTA. MTA was introduced as a root end filling material to begin with at the start, and it has been used quite successfully, and its setting time is longer than Biodentine. So I don't really think that there should be any problem, but there's like a controversy on that. I have personally used it as an apical plug quite successfully, but never used it as a surgical, so I do not comment on that. So in terms of viscosity and flowability, as I said, so it has a really nice flow, and it's really important to stick with that amount of water and powder that the manufacturer said. And that's one of the reasons that I like the new one more, because if you get a thicker mixture, that's associated with a lower water cement ratio, which results in a higher porosity and more voids. So in the past, in the previous Biodentine, we had to add water, so there would be an element of human error. Whereas in the new one, the manufacturer has taken it out of our hands. So it's exactly accurately measured the amount of liquid, amount of powder there in one capsule. So we have no role in deciding how much water should be added. So I remember that when we were using the previous one, some of our colleagues had said that they kind of like manipulated, they increased or reduced the amount, and they thought that it can alter the setting time. So they were thinking that they were winning this game by changing the setting time. But it's actually wrong, because this is accurately measured, and it has to be like that. So anyway, in XP, it's done now. Okay, porosity. This is a very important part, a very important characteristics of this material. I'm actually going to show you this picture so that I can explain it better. If you look at this picture, this orange part is the calcium silicate hydrate, the part that is basically hydrated Biodentine, and they start to kind of like grow, and then they aggregate to each other. So this is the part that is not hydrated yet, calcium silicate. These are the parts that are hydrated, and in this process they leave some pores between them. And if you look at those pores, those pores are connected. So there will be a lot of pores connected to each other and then connected to the outer surface of the Biodentine. So inside the set material, which is static and solid, we have a network of liquid, which is dynamic. And that liquid, which is called pore solution, is full of ions. And that is really important for that biological and chemical properties of the material, because that's what helps with the exchange of ions, which then from which we can get all those characteristics, biological and chemical characteristics. So that's basically internal transportation network, and it can have an interaction and ion exchange with the surrounding environment as well. And as I said, it's full of ions such as calcium, hydroxyl, silicate, carbonate, and you'll see that why they're important. The pH of this pore solution is also important. The pH, especially in the beginning, is quite high, and that's because the pH is basically dependent on the amount of calcium hydroxide which is released, which reflects the progress of the hydration reaction, because we know that in the reaction, when calcium silicate gets into contact with water, we have calcium silicate hydrate and calcium hydroxide. So as the reaction taking place, we have more and more production of calcium hydroxide, and then calcium hydroxide can increase the pH. So in the beginning, we have a high pH because we have a high release of calcium hydroxide. It's about 1.6 to 12.3, but then it starts as the creation of calcium hydroxide drops, then the pH drops as well to 8.9 to 10.7 within 4 weeks. So Biodentine in relation to dentine is actually quite important because basically we say that biodentine is a dentin replacement material. So it's very important that how they react with each other. So hydrating biodentine is a rich source of ions, which we talked about. By diffusing into the surrounding environment, these ions can modify the equilibrium towards the formation and precipitation of minerals. And that's what we need in perforation repair. That's what we need in regenerative endodontics. That's what we need in vital pulp therapy. We want the precipitation and formation of minerals on the cement surface, within the structure or the adjacent tissues. And the whole, basically, all these changes collectively can mediate and trigger cellular and metabolic pathways in favor of regeneration, mineralization, and bone formation. So these three, regeneration, mineralization, and bone formation, is the ideal outcomes that we want from all these procedures. So we have a really nice contact between the biodentine and dentine, creating a good seal. So how the seal is achieved is actually achieved by both micromechanical interaction and chemical interaction. So so if you look at this picture, in this picture, you will see that there are some like tag-like structures which can penetrate into the dentinal tubules and create that micromechanical seal. So I personally had this question that if we want to have this tag-like structures, then shouldn't we open the dentinal tubules by the form of, I don't know, by using some acid etch or using EDTA maybe? And the answer was no, but nobody really told me that why. Eventually, I found out that it's like, I'm saying it based on the things that I have read, so don't really quote me on that. But this is my understanding, that if you know that how the bondings work, some types of bindings we remove the smear layer completely, so we have like empty dentinal tubules. In some of them we don't remove them completely, and we basically alter the smear layer. So it's kind of like we're incorporating that smear layer into that bond layer. So it's because there is a chemical interaction between the biodentine and the dentine as well. How? If you remember, I told you that we have the ions of silicate and calcium in that liquid, in that porous solution. And in dentine, what we have is phosphate. So put them together, we will get what? We will get hydroxyapatite, right? So by the formation, by those hydroxyapatites, so we have kind of like chemical reaction as well, micromechanical seal as well. So we get really nice seal, which improves the shear bond strength to the dentine. All right, this is basically what I said, the apatite crystals. And this reaction occurs without the need for prior acid etching, primarily through the calcium and silicate ions released from the cement interface. Okay, and we're getting to the end of that science now. Something that I really needed to emphasize is this layer, the layer between the biodentine and the dentine. This layer is water permeable. It's important. Why? Because we want fluids, we want the exchange of fluids from biodentine to dentine, from dentine to biodentine. Okay, and this layer allows that to happen. So it can take place, it can reach and infiltrate into the superficial layer of the cement close to the interface here. And also it can take place in the opposite direction. Fluids from the cement can infiltrate into the dentine, and this layer of dentine appeared structurally altered. And that is especially important when we want to in vital pulp therapy, because we want that exchange of ions for that dentinal complex. Okay. So biocompatibility, some said that in the beginning, biodentine can be toxic, and it can maybe related to the huge amount of calcium hydroxide which suddenly releases. But several studies, especially this study, shows that biodentine and MTA Angelus cements had a low cytotoxicity, which further decreased with aging cycles. Okay. So let's talk about vital pulp therapy. All the science is finished now. Let's go into more clinical stuff. Vital pulp therapy is a minimally invasive, biologically based treatment supported by mainly this study and a few more studies, which I will show you completely in the next slides. Why we want to do vital pulp therapy? I always use this for my students, and I think when you hear it, it's really hard to unhear it. So imagine a battlefield that the soldier has been fighting a hard battle, and now they are injured. What do you do? Do you kill them because they're injured, or do you actually look after them and help them heal, put a bandage on their wound and help them heal? That's the tooth. The tooth has been fighting a really hard battle. Now it needs help. It's crying for help. It's vital. You do your sensibility test, and it's vital. What it means that the tooth has pulse. It's vital. It's crying for help. So instead of killing it, maybe we need to help for it to heal. So apart from that drama, these are basically the main reasons that we want to do the vital pulp therapy, because no root filling material is as good as pulp. The pulp is the best. What kind of root filling material that can go into all those nooks and crannies, fins, isthmuses, lateral canals, etc. That's one reason. Another reason is that the vital pulp has some characteristics that no other root filling material has. It has the potential for dentin deposition. When there is a damage, it can defend, it can deposit dentin, and it has an immunological response, and it has proprioception. So one of the main reasons for the endodontically treated tooth to be lost is fracture, not actually endodontic failure. Why fracture happens? Because the root canal treatment reduces the structural strength of the tooth through removing of the tooth structure, and also changes that happens in the dentin due to the process of getting non-vital and root canal treatment itself, and the patient loses proprioceptions. These all put together can cause fracture, more fracture in root treated tooth. So we were basically avoiding all that. And also, as I said, RCT obviously is destructive and is poorly carried out in majority of cases in general practice because it needs higher skill, whereas vital pulp therapy is technically easier to do, less technically demanding. And also it causes it involves minimum intervention, reducing hard tissue removal, right? So, and also it's less time, less cost, and we never get all those complications of root canal treatment such as discoloration, fracture, instrument fracture, perforation, etc. Okay, so the reasons for pulp damage. I'm just going to check and see how I'm going with time. I think we're still okay. Okay, so the main reason is obviously caries, which is the largest non-communicable disease on the planet. And second reason is the dental trauma. And another reason is restorative procedures, which is obviously the accidental pulp exposure. Okay. So vital pulp therapy, for years, the focus of vital pulp therapy was on the preservation of the reticular pulp in immature adult teeth, because we wanted the continuation of the root development. Now, age is completely out of the picture, and we know that vital pulp therapy can be considered at any age, according to the study which is done by Ascari and Edward, who are basically in the Scheidbest University, which I did my training in. All right, so we can consider them in any age in mature tooth and quite successfully as well. So what is the protocol? I cannot stress enough that the most important thing with vital pulp therapy is case selection. If we do the case selection right, then we probably, maybe 80%, we have guaranteed the success. And case selection needs good and accurate diagnosis, which is the most challenging part. And then obviously we have to remove the enemy, which is, in case of caries, removing a bacteria, and then follow a very strict aseptic approach and use the right material, which we'll get into all of them one by one. Now, diagnosis. When should I consider vital pulp therapy? I need to assess the status of the pulp for that. If I want to keep the pulp vital, I need to make sure that that pulp is viable. But is it even possible? It's really difficult. The terminology that we have for different stages of the pulp is a traditional one, and it's not quite accurate, but we are still using it, is normal pulp, reversible pulpitis, irreversible pulpitis, which by the way can be symptomatic or asymptomatic, and pulp necrosis. When should I consider vital pulp therapy? Okay, so we have these to make that decision. We have the history taking, we have the clinical findings and examination, radiographic findings, and direct visualization. Let's go into them. Obviously, the first thing that we want to know is very thorough pain history. Socrates, I'm not going to go through that. So where is it? How long does it take? All that thing that you know, and it's mentioned here. But from all of those, probably the most important thing is there spontaneous pain? And that is, according to what I have read and according to my personal experience, this is probably the most important thing. And I will get onto that later again. So how is the diagnosis traditionally made? By these. We do the visual examination. Is there a sinus tract? Is there a crack on the tooth? Is there a fracture on the tooth? Is the remaining of the tooth structures even restorable or not? Or sometimes you need to think about the whole picture, basically. For example, if a tooth is going to be the abutment for a long bridge, or not even a long bridge, like a normal conventional 3-unit bridge, for example. And I'm thinking that, okay, vital pulp therapy might be successful, might not be successful. So let's think about the fact that if it fails and it needs root canal treatment, am I compromising the 3-unit bridge? So maybe in this case, I would go with root canal treatment. Okay, so we need to see the whole picture. It's not just the pulp status, also what is going on. In a mouse with a really bad poor oral hygiene, lots of care is probably not the best idea. If the periodontium is not stable, if a periodontal status is not stable, maybe not a good idea. Okay, so we need to think about that, pocket mobilities, and then sensibility testing. Is there a response? If there is it mild, is it moderate, is it delayed, is it severe? Where do we do the sensibility test? In just one aspect and just on the occlusal surface? Not enough. We need to do it in different aspects. For example, a lobar molar, I need to do it in mesiobuccal. I need to do it in mesiolingual, distobuccal, distolingual, the whole thing. And then if I can create sensitivity, how long does it last? Is it instantaneous or is it lingering? Percussion test, although I have done a, well, theoretically, we think that if there is percussion, tenderness to percussion, then there is an involvement of periodontal tissue, periapical tissue, so probably it's too late. But I have done vital pulp therapy, and I will show you the case successfully in a case which was actually tender to percussion. So it's not, there's no really like white and black in here. There is a lot of gray areas. So in summary, sensibility test in all aspects, as I said, spontaneous pain, which I said the most important thing, positive percussion test, and direct observation for necrosis or hyperemia. About the spontaneous pain, I have done, it's my personal experience. So as I said, I'm just sharing my experience, that's all. I've done something about 40 cases of vital pulp therapy. Only 2 cases failed. Only those 2 cases had a spontaneous pain. So in one of them, I opened the tooth. It was hyperemic, but I cut it and reached the, and this is what AAE recommends basically. So I did the full pulpotomy. I could see under microscope that the pulp was really nice and healthy, pink. I could do the hemostasis. We will get into that in a minute. Everything seemed perfect, apart from the fact that the patient had a spontaneous pain, and I did the vital pulp therapy, and it failed really badly, because in these cases, if it's going to die, it's going to die painfully. And the patient came back to the practice in tears, which was really embarrassing because I wasn't even in the practice. Somebody else had to do the extirpation. So I don't have a good experience with the spontaneous pain. I was talking to some of my colleagues. Some of them said that they have done some vital pulp therapy in cases with a spontaneous pain successfully. So that's my experience. So I'm a bit apprehensive when there is a spontaneous pain. Okay, so if you look at this, this is from last year's World Endodontic Day, which is approaching, by the way, on 16th of October by IFIA. Dr. Domenico Ricucci showed these nice pictures, which shows in reversible pulpitis, you have the bacteria close to the pulp, but not in the pulp. So in the pulp, we don't have any bacteria, we don't have any necrosis, and that's usually associated with reversible pulp inflammation symptoms. With irreversible, however, you see the bacteria and necrosis in the pulp. Okay, so they concluded that the clinical diagnosis of normal pulp or reversible pulpitis matched with the histological diagnosis in 96.6%. So it's almost really like accurate. Whereas in irreversible pulpitis, it's only 84.4%. So accurate diagnosis and treatment planning cannot be achieved by clinical symptoms alone. And this is why a thorough discussion with the patient is crucial. You need to tell the patient that it might work, it might not work. So they need to be aware. They need to know that what they're signing up for. Okay, so why those symptoms are not, well, surprisingly, AAE, because we have two guidelines, right? AAE from American Association of Endodontics, and we have the ESC position statement, European Society of Endodontology. And they are, in some areas, they have common opinion, but in some areas they don't. AAE most of the time says that based on symptoms, we make a decision whether or not to do the vital bulb therapy. And it's not enough. So based on symptoms, you cannot do that. First of all, dichotomy of salvageable and non-salvageable not reflected by the reported success of partial or complete pulpotomy when only symptoms are indicative of the diagnosis. Second, and that's the study, second, 60% of irreversible pulpitis are asymptomatic. 60%, that's more than half. And that's a study, and pain is very subjective. So when we just think about something completely subjective as the reason, as the tool to make our diagnosis, is a bit scary, to be honest. So we need more objective measures of pulpal inflammation. For example, carious lesions depth, which is not considered an AAE bit, but ESC really talks about depth. That's one thing. Second is the activity. It's important to clinically assess and see that, okay, that deep decay, that deep caries, is it active or is it arrested? What is the progression rate? What is the color? You know that the darker they are, usually they are arrested. Sensibility test, so something more objective, something that you can see, something that you can measure. And potentially the best thing would be biomarkers such as MMP9, but we don't have like clinical access to that. And even if we do, there is a big problem with it, because in order to get that biomarker in the quantity that can be measured, you need pulp exposure. We don't want to expose the pulp just for the sake of knowing that what is the biomarkers. The amount that we can get from dentinal tubules is not going to be enough. So still, I know that one of my really talented students is now doing a PhD working on biomarkers. I'm really excited to see that what they will achieve, but I think it's the future that we can hope maybe to have a better, more accurate diagnosis of pulpal status. But until then, we are stuck with the more crude ways of doing that, such as sensibility testing, etc. Radiographic examination is basically to assess the depths of the caries. We can use bite wings, which is very accurate assessment of the depths of the caries. You can use periapical, but CBCT is not recommended. CBCT is not something that can help us with the status of the pulp. Okay, so caries depths, according to European Society of Endodontology position statement, we have deep caries and then we have extremely deep caries. Deep caries, something like that, are caries reaching the inner quarter of dentin, but with a zone of hard or firm dentin between the caries and the pulp, which is radiographically detectable when located on an interproximal or occlusal surface. In these cases, there is a risk of pulp exposure during operative treatment. There is a risk, but it's not definite. Whereas in extremely deep caries, caries penetrating the entire thickness of the dentin, radiographically detectable when located on an interproximal or occlusal surface. Pulp exposure is, and most of the times, is inevitable. And that's very important to know these deep caries and extremely deep caries in the decision making. And I'll tell you how. So why it's important? Because according to this study, significant levels of inflammatory cells are not observed in the pulp until the caries has penetrated to within approximately 0.5 millimeter of the pulp. So see that it's an objective thing that they can actually see. It's not like pain, which is subjective, and it is proven by this study that we don't have, it's not, if it's not yet as close as 0.5 millimeters to the pulp, we still have a good chance that there is not too much inflammation in the pulp. So direct visualization is basically, we said that in the absence of clinically available molecular biologic tests, direct observation of the pulp, which is used by use of microscope, is recommended by AAE, okay, which can give relevant information for determining the suitability of the case for vital pulp therapy. First, a misdiagnosed necrotic pulp can be accurately identified. So if the pulp is exposed and it's necrotic, you can see it. Secondly, direct observation of pulp tissue during and after achieving hemostasis offers additional diagnostic information about the condition of the pulp tissue. So utilizing direct visualization of the pulp, it appears that even symptomatic pulps may be candidates for vital pulp therapy. This is what AAE says, and this is what I did, unfortunately failed. I don't know, it was me. I'm not saying, please don't take my word for it. Because under microscope, the pulp seemed okay. The patient had spontaneous pain, severe pain. We did that and it failed. But I know that it's not always the case. So what are the problems with direct visualization? First of all, if there is necrosis, direct necrosis or pus, yes, it can be seen. That's true. But hyperemia is not really reliable. I mean, how do you, it's again, it becomes like it's not like really measurable. How do you know that what is it that we call hyperemia? Clinician to clinician can be different. And again, based on these guidelines, they say that if you can stop the bleeding in 5 minutes, ESC says, for example, in 5 minutes, that's fine. So if it doesn't stop in 5 minutes and it stops in 7 minutes, it's not. I mean, it's a very crude way of really deciding about the condition of the pulp, the hyperemia. So direct visualization, yes, maybe, but it's not. Again, it's basically the hyperemia is the surrogate endpoint. It's not, it shows the amount of inflammation, but it's not very accurate. Okay, so diagnosis, sorry, let me just get back to it. Diagnosis. So basically, you have to just put everything together. You take your history, you do your clinical examination, you do your sensibility test, percussion test, all that. You have the radiographic examination in front of you, caries, deep caries or extremely deep caries. Based on all that, you make a decision whether or not to go with vital pulp therapy, but we can always get it wrong. So it's very important to have this discussion with the patient. Look, it might fail, it might not work, so they need to know that what they're signing up for. And it's very, very important to get the consent. So the second part is the caries removal. It's the part that is the biggest clash between those two, AAE and ESE. And I'm not going to tell you which one to follow. I'm not going to tell you which one is right, which one is wrong. I'm going to tell you that what I believed was right, now I have changed my mind. I will tell you why, and I will show you some evidence. I will show you some studies and everything. I think that you should make your own decision. Before going into that, I just wanted to talk about a little bit about the consensus by ICCC, Delphi Consensus on Caries. From this ICCC, one of the C's is caries, consensus, collaboration. In what order, I can't remember. You can find out. Okay, so based on these, so basically the main point is dental caries is now considered a disease, not an infection. Look, the infection that we have in dental pulp, and endodontic infection is an infection. With infection, we want to remove the infection. We want to remove the bacteria. And that's what we do in endodontics. All these irrigation, solution, activation, different material, all our focus in removing is on removing the bacteria from inside the canal. But that's different from caries. Caries is not an infection, it's a disease. It's a disease which is caused by an ecological shift and that ecological shift is the result of frequent access to fermentable dietary carbohydrates, which leads to a move from a balanced population of microorganisms which are low in karyogenicity to a microbiological population of high karyogenicity. So it's a disease. It's a dysbiosis. Okay. So if it's not an infection, then maybe we should think about, maybe we need to, we're not mechanics. For a long time, the dentistry was basically a mechanical job. There is caries, I'm going to remove it, I'm going to cut everything, restore it, and that's done. Now we are thinking about being a healer. And you know that if we are healers, we need to be aware that we are not doing the healing, basically. Healing is what the body does. What we do, we lay the foundation for the body to heal. So if we have that shift in ecosystem, in that ecological shift, maybe we can change that. We can shift it back. If it's because high frequency sugar intake, maybe by changing that, it can change. And it's biofilm related, disruption of the biofilm. They all can change, and then the body can do its job. So that's the whole basis on selective caries removal, which we'll get into in a minute. So in this, according to those consensus which I told you about, we have the terminology of soft dentine, leathery dentine, firm dentine, and you will see that the soft dentine is the dentine that we can easily remove it by hand instruments. Leathery dentine, again, can be removed by hand instruments, but it's slightly more resistant. Firm dentine is more resistant, and then we have the hard dentine, which is a scratchy and you get that sound of a scratch, which is called, if I'm not mistaken, dentine, cry of the dentine, basically, cri dentinaire in French, I think. So we have that terminology, and also we have the terminology of the caries removal, which is no removal of carious tissues, selective removal, stepwise removal, non-selective. Let's see what they are. And this is a really nice diagram. Now they are approaching the caries from this point of view, which first let's think about if the caries are active or not. If they are not active, then no intervention. If they are active, then we need to look and see that if they are if they are cavitated or not. If they are not cavitated and if they're cleansable, because I said that we are going to basically provide some situations that ecological shift can be reversed. So if it's cleansable, if not, then we can maybe make it cleansable by some changes in that caries. Maybe, I don't know, maybe just smoothen it a little bit, make it possible for the patient to disrupt that biofilm. Then the body will do its job, and then we will have the arrested caries. So this is a really good, this is really good to consider, and that I recommend Delphi consensus to go through it, because I can see that so many dentists are still quite aggressive with the caries removal, so maybe it's not necessary, and we want to preserve the tooth structure. So the aim is trying to keep the sound dentine and also the basically mineralized dentine, which is the arrested caries, and also the non-mineralized dentine that can be mineralized. So we can maybe keep that too. I'm just going to skip that now. What is the selective removal? So selective removal is based on these two studies, Maltz and also Bjorndal, if I'm pronouncing it right, I'm not sure. And I'll give more detail about those studies later on. So it can be done in one stage, or it can be done in two stages, but two stages is called a stepwise and it's the selective caries removal to soft or firm dentin. So we don't remove all of it. We go into the soft dentin or firm dentin, we then remove that leathery dentin. We just leave the firm dentin or soft dentin. We don't remove it, we don't get into the hard dentin. So are indicated in deep caries lesion when the tooth is asymptomatic or has signs and symptoms indicative of reversible pulpitis. So these are, sorry, let me just have a very quick look at the time. I think we're all right. Okay, so when we have, we said that we do our history, we do our clinical examination. Now we have a case with the symptoms of reversible pulpitis. We don't have any spontaneous pain, we don't have lingering pain, we don't have any symptoms which is telling us that it's irreversible. We have the reversible pulpitis. Now we look at the radiograph, and the radiograph, we see that we have deep caries, meaning that we are not going through all the way to the thickness of the dentin. Okay, in this case, now we can go with selective. 1 stage or 2 stage. I don't like 2 stage, I'll tell you, but I'll explain that how it's done. Meaning that we don't have to remove all the caries, and the aim is preventing the pulp exposure. Okay. ESC position statement says that selective caries tissue removal, 1 stage or stepwise, is advocated in teeth with reversible pulpitis, provided radiographic assessment indicates caries has progressed to no deeper than pulpal quarter, which is deep caries, not extremely deep caries, with a zone of dentin separating the caries lesion from the pulp chamber. In these cases, we can go with 1 stage selective caries tissue removal or 2 stage stepwise. I'll explain to you now what they are. And that statement is based on these 2 studies, both clinical. We have randomized clinical trial by Berndal in 2017 with 5-year follow-up, and also randomized trial by Moltz in 2012. So what is non-selective removal? Non-selective removal, according to ESE, in these cases, is no longer regarded a treatment of choice in deep caries. Deep caries, I'm emphasizing deep caries. We're not talking about extremely deep caries. We are talking about deep caries lesions, with recent consensus considering it to be over-treatment. Okay. So AAE takes completely opposite stand and says that complete caries removal is essential to eliminate infected tissue and visualize pulp tissue. Again, AAE says that I want to see the pulp. I want to see that what's the situation. Okay. Other magnification and residual caries. The reason that they say that residual caries compromise necessary observations of pulpal inflammation levels and areas of potential necrosis. Accordingly, predictable management of vital pulp tissues should not be performed without complete removal of both demineralized enamel and infected dentin. Completely different. ESE says that the destructive nature of conventional dental treatment and concerns of over-treatment and the restorative cycle have led the professions to promote minimal invasive biologically based treatment. So we don't do the non-selective, we do the selective one. All right. So which one to follow? AAE or ESE? As I said, I'm not going to tell you which one to follow. I'm just going to show you some evidence of both, and then you can make your own decision. I was following AAE for a long time. I did a lot of vital pulp therapy following AAE successfully. After Pulp Summit in January, when I talked to some of my colleagues, especially my dear colleague, Dr. Abhijit Banerjee, and also Dr. David Edwards. So we kind of challenged each other. I was challenged. I didn't accept it. I was quite stubborn, but I came home with this idea that maybe I'm wrong. And then I started to do my own research. It took me 6 months. It didn't happen overnight. Now I'm a converter to ESE. Now I follow ESE. I'm not telling you to follow AAE or to follow ESE, so I'm just going to give you basically both. You do your own research, and then you decide which one to follow. So ESE says that the remainder of the bacteria can be eliminated by the pulp and antibacterial characteristics of biomaterial. We have Biodentine with really fantastic antibacterial characteristics. And we have the pulp, and that surface which I told you about between the biodentine and the dentine, that surface which then liquid can be exchanged. It's all these things can happen, and basically antibacterial capacity of the biodentine and also immunologic response of the pulp can take care of bacteria if we have a very good peripheral seal. That is a must. So in the periphery, we need to remove the caries completely, non-selectively, to hard dentin, because here we want the seal. If we get the good peripheral seal, the bacteria which are entombed under that, then they will lose their contact to high sugar intake. So the ecological shift can be reversed. And also we have obviously the antibacterial capacity of the material and also the pulp. So evidence supporting that selective has better outcomes than non-selective. I will show you those evidence. Here are a lot of things that you can maybe take a screenshot of that. So following selective, there's reduced risk of exposure with selective techniques. Selective versus a stepwise, 77% versus 56%, and that's why I personally prefer selective. Stepwise means that you put a kind of like a provisional material on the caries, and then you come back after some time and then remove it to the arrested dentin. I don't think that is necessary personally, and I've seen it. Some other clinicians also recommend that maybe just one step is better, but that's something that is mentioned in the position statement. Reduce risk of losing vitality, and that's the main goal basically. We want to keep the vitality. With the selective, we have the reduced risk of losing vitality, and these are the references you can go. By the way, this slide is credit to my colleague, Dr. David Edwards. I need to say that. And he kindly and generously shared this slide with me. 5-year survival was 80% using selective, according to this study which I showed you before, and a stepwise 60% survival versus complete. So stepwise gave 60% survival, whereas non-selective gave 46%, and that's one of the main areas. One of the main studies that ESE position statement is based on, beyond all, in 2017, and also reduced post-operative symptoms. Okay, so these are the studies behind ESE position statement. These are the studies behind AE position statement. So they also back it with the studies, and they say that you have to eliminate all the infected tissue, visualize pulp, and everything that I told you before, non-selective basically. Okay. So now let's explain that. Indirect pulp capping is no longer recommended. Indirect pulp capping means that you remove everything to hard dentin and then you put biocompatible material. Selective says that one stage application of a biomaterial onto a dentin barrier in an indirect one-stage selective caries tissue removal technique, removal to soft or firm dentin, immediate placement of an permanent restoration. Okay. So indirect pulp capping is not recommended. Here is the stepwise, which I told you it can be done in 2 stages. Application of a biomaterial in an indirect 2-stage selective caries tissue removal technique, temporary restoration placement between visits, and then re-entry in 6 to 12 months. First stage involves selective caries tissue removal to soft dentin to an extent that facilitates proper placement of a temporary restoration, and second stage then removal to firm dentin, final placement of a permanent restoration. It's really not necessary. We can do it in 1 stage. As I said, indirect pulp capping is not recommended. Okay. What about direct pulp capping and or pulpotomy? Okay, so now imagine that we have a case, again, with the symptoms of reversible pulpitis, not irreversible pulpitis, but on the radiograph, we have extremely deep caries. Extremely deep caries means that the pulp exposure is going to happen. It's inevitable. This is a different story. In this story, when the pulp exposure is going to happen, we are removing everything. So it's non-selective. We're not going to, when the pulp exposure is happening, because the philosophy behind not removing all those caries and going with selective was to avoid pulp exposure. When the pulp is going to be exposed anyway, we want to get rid of all that. Okay, so it's complete removal of the indirect pulp gap following the preservation of an aseptic working field, application of a biomaterial directly onto the exposed pulp prior to immediate placement of permanent resorption. We can also do the full pulpotomy. We'll get onto that. So protocol, strict aseptic approach. Okay, so look at that. So we need to have very good isolation and then clean the whole area with sodium hypochlorite. It's very, very important. So the most important one is part is case selection, and after that aseptic. Okay, so completely disinfecting it, and then complete caries removal from the walls first. What we do is that, imagine a very large caries lesion. We remove all the caries to hard dentin from the periphery. Then we wash the cavity with sodium hypochlorite. Then we change our burr into a new one because now we're going to close to the pulp, and then remove caries from the pulpal bore or floor, and then wash the cavity with sodium hypochlorite again. And don't underestimate that. That lavage with sodium hypochlorite is super, super important. Okay, so deep caries to hard dentin in the periphery, selective or to soft or firm dentin in pulpal floor, extremely deep caries, non-selective everywhere. But with an order, in the periphery first, and then cleaning it, and then go towards the pulpal floor. So what is the importance of sodium hypochlorite? Is hemostasis, obviously. It helps us to achieve that hemostasis, disinfection of the dentin pulp interface, biofilm removal, chemical removal of the blood clots and fibrin, clearance of dentinal chips along with damaged cells at the mechanical exposure site. According to this study by Balal, if the cavities were washed with saline, we had a pulp survival rate of only 55%. Changing the saline to sodium hypochlorite changed that number to 89%. So you can see that it's a staggering difference between the two. So it's very important to do that final lavage with sodium hypochlorite. Okay, so again, according to ESE, and pulp exposure, hemostasis and disinfection should be achieved using cotton pellets soaked ideally with sodium hypochlorite 0.5% to 5%. And if hemostasis cannot be controlled after 5 minutes, then what? Then we start, shall we just give up? No, we just start to remove pulp tissue. A little bit more, a little bit more. It can be partial or eventually maybe full pulpotomy until we reach the area of the pulp which looks more healthy. And we can achieve that hemostasis in about 5 minutes. If there's pulp necrosis, and obviously we cut it as well to achieve the vital and healthy pulp, and that should be done with a faster speed there under the coolant. Protocol is basically pretty much the same with AAE, which only just extended the time from 5 minutes to 5 to 10 minutes. Just checking the time. Okay, so it's about 1 hour, so I need to be speeding up a little bit. So about the bandage, now it's time to put the material. If there is no pulp exposure, we can use calcium silicate cement such as Biodentine or glass ionomer, but with pulp exposure, we always prefer to use calcium silicate cement. Calcium hydroxide is now completely out of the picture according to ESE position statement, and we have many studies to show that MTA has much better results compared to calcium hydroxide. And you can see that again thanks to Dr. David Edwards, which shared with me this slide. You can see that under calcium hydroxide we have the hard tissue formation this much, and it's MTA, so you can see the difference as well. So modern calcium silicate cement such as Biodentine obviously has the advantages, which with the MTA we had the limitations, which included the time that needed to set the material, and also discoloration was the big disadvantage. With the new ones, we had to reduce costs, reduce setting time, and also we don't have the problem of tooth discoloration. Okay. Why Biodentine? Because if you look at that, you will see that tricalcium silicate hydraulic cement releases calcium and hydroxyl ions, which we talked about, and because previously I mentioned that because of all that biological effects, it usually helps. It's a good material to help us achieve, you know, the bone formation, regeneration, neoangiogenesis, etc. So I'm just going to show you how to use the XP here. This is the XP, which comes in two different packages. One is 200 and the other is a 500. So what is the difference? The difference is the amount of the material in the capsule. So in the 200 you have a smaller amount. One of the problems that we had with the Biodentine before is that there was too much product in it, and so it could go to waste. With 200, I usually use it, for example, for I usually use it, for example, for perforation repair when I don't need a large quantity of the material, and 500 I use it for bulk fill, which I will show you in a minute. So it comes in this capsule. The water is in that black bit at the end, and the powder is inside this water bit. We put it in this machine which comes with it, and then we lock it, and that pushes the water into the powder. As I said, it's been taken when you move the handle, then that pushes the water into the powder. So we don't need to really do that. It's pre-measured by the manufacturer, and then it goes in there locked, and we then mix it for 30 minutes. And using this machine is, again, is an advantage because it's calibrated exactly for the purpose. And then there is a kind of like a gun-shaped material, it's a gun-shaped tool which we use to basically dispense that material. This handle should be placed in a parallel way, otherwise it won't go in. And then we put it there, lock it there, and then it's ready to be used. And this nozzle here can be bent as well. You'll see in a minute. So we can bend that nozzle, which makes it easier to apply the material. And if I'm speeding up a little bit, you can see that, then you can apply it. It's much easier to apply. Okay, so right, so let me show you some clinical cases. This is a case that I did. It's a young man, about 20, I think it was about 29 years old, had deep caries, the symptoms of reversible pulpitis. It had a tenderness to percussion as well. After I removed, as you can see, because I had the pulp exposure and it was really deep, extremely deep cavity, I removed everything all the way to the hard dentine. As you can see, there was pulp exposure, quite large pulp exposure as well. Hemostasis achieved by sodium hypochlorite, saturated cotton pellet, and then I put the Biodentine. That's how I used to do. I do a different technique now. I'm going to show you. Biodentine, 12 minutes. We wait until it's hard enough to get cleaned, and then you can put the composite on top. I usually put a layer of flowable composite, and then I do the etch and rinse, because with the flowable composite I use weaker etch, which is the self etch. Basically, after that, then I can use the etch and rinse technique, and then seal the cavity with composite. And this is the 12 months follow-up. As you can see, the dentinal bridge, this is here Biodentine. As you can see, the dentinal bridge is formed really nicely. The patient has no symptoms at all, no tenderness to percussion, and it's doing well. This is another case, very extremely, again, deep caries. And as you can see, after removing all that, we had the pulp exposure, Biodentine placed, cleaned, and then a layer of flowable composite first, which then was followed by normal composite. Another case similar to that, Biodentine was placed. As I said, I have a different approach now. I'm going to show you, and this is the final bit. I did the polish, by the way. It wasn't untidy like this at the end. This case was again very deep, upper 7, but upper 8 was extracted later on. There was a pulp exposure. I put the Biodentine. Do you see this rough surface on Biodentine? Is wrong. I don't do that now. It shows that there is a lot of manipulation, and when we manipulate it too much, we kind of like mess with the structure. Okay, and then composite filling was done, and this is the 12 months follow-up, and the 8 was extracted. So I follow up this case very closely because it's actually my husband's tooth. So I follow up every day. It's been a year and a half and it's fine, no symptoms, no problem, no tenderness to percussion. It's doing well. All right, so what I do now, I have a different approach at the moment. So this one, let me just go back. This one was a 9-year-old, was a 12-year-old child. As you can see in the radiograph, it's extremely deep caries, right? It's gone all the way to the pulp. And obviously I was expecting to have that, but again, the symptoms of reversible pulpitis. So after removing all that, I achieved the hemostasis really nicely with sodium hypochlorite. And then what I do these days is this. I did a bulk fill with Biodentine with XP 500 with very minimum manipulation. As you can see, it's a shiny surface on the top, and that's how it should be, because it shows that the material, I didn't manipulate the material too much. I let the material to crystallize, to do the setting on its own without really too much intervention. Then I saw this patient, I released the patient. Obviously you wait for 12 minutes or a bit longer, and then you can discharge the patient, bring them back after 3 months, which I did. All the symptoms was gone, the tooth was vital, no problem, tenderness to percussion, no tenderness to percussion, was sensibility testing positive in all aspects. So I trimmed the Biodentine a little bit, and I did you need about like 2 to 2.5 millimeters, which is the thickness of the composite that you really ideally need in occlusal surface, really, and then did the restoration. Sometimes we need to do the full pulpotomy. I have personally not done a full pulpotomy, but I just put the picture here just for you to see that it's all completely cut down to the pulp stems, and then we can do the bulk fill, and then in the future we can bring back and trim the Biodentine, and then we can put the composite filling. Okay, just checking the time again. In trauma cases, when the pulp is exposed, we can basically use the vital pulp therapy, and that's called class 1 pulp exposure. Class 1 pulp exposure are the pulp exposures which is done through the sound dentin. It can be because of trauma, it can be because of accidental exposure, not carious dentin. In these cases, I would personally remove, depending on the time really, it usually takes some time for the patient to get to us, I would remove a few millimeters of the pulp to get rid of that contamination, that may be necrotic tissue at the top, and also to create a space for the Biodentine, and then do this. With the trauma case, I'm just speeding up a little bit so that I can show other cases. With the trauma, one of the very important things that we need to take into consideration is that when you have a crown fracture, complicated crown fracture with the pulp, obviously complicated means that you have pulp exposure, there is a possibility that maybe there was a luxation injury. Okay. In these cases, if we have a combination of complicated crown fracture or crown root fracture and luxation injuries, the possibility of pulp necrosis is high. So with vital pulp therapy, it's very important to do the follow-up. With trauma, is even, especially in younger patients, is even more important. Why? Because if the pulp goes necrotic, then there's possibility of external inflammatory resorption, and external inflammatory resorption progresses really rapidly in children. So we need to really keep an eye on it closely. We do a regular follow-up, and at the first signs that the pulp necrosis is happening, we should intervene in order to prevent the chance of external resorption. Sorry. And as I said, the follow-up is very important. Normally we do a 6 months follow-up supplemented by periapical radiograph, and then at 1 year. But as I said, it's very important to do it even more regular follow-ups in trauma cases, especially with the luxation injuries. With full pulpotomy, obviously, we won't be able to do the sensibility testing. With partial pulpotomy, direct pulp capping, you can. I just wanted to mention this study, PIP study, which is a big study, which is going on which has been going on for a few years in the UK-based study, and I'm hoping, very excited to see the results. Hopefully, in I think 2026. It's been carried on in several universities, including the Liverpool University, which I'm close to. It's basically comparing the effectiveness of full pulpotomy and root canal treatment for irreversible pulpitis in permanent premolar and molar teeth in adults. And the study is taking place in primary care dental practice across Scotland and England. Keep an eye on this. I'm personally very excited to see what will be the results. I think it's a really very valuable study. Okay, so very quickly on the effect of biodentine on pulp dentin, and then I'll show you the other cases that I have done apart from vital pulp therapy. One of the most important things that the biofilm does, and it also reduces the pain, is the resolution of inflammation. And it also causes neoangiogenesis, pulp fibroblast proliferation, and colonization. I will show you the studies for all of that, so it's not like a list of things. Proliferation and migration of dental pulp to stem cells, and also their differentiation into odontoblast-like cells to synthesize reparative dentin. So the dentinal bridge that you could see in the case that I showed you, that is basically formed because of the differentiation into odontoblast-like cells. Then they can create the reparative dentin. All right. This is the study for the fact that biodentin reduces the inflammation, and also it can result in neoangiogenesis. Vascular endothelial growth factor expression was upregulated by all 4 tested materials, one of which is biodentin, Emdogain, although Emdogain had the higher result compared to the others. And then dental pulp stem cells recruitment, you can see in this study. I'm just going through them. And okay, so now let's go into other cases, other scenarios that I have used biodentin successfully. One is perforation repair. I love this material for perforation repair. As you can see, there was a patient which came to me with this scenario. As you can see, that there was a big intraoral fistula which was draining actively. The patient had pain, and this was the radiograph. And then, sorry, I think I messed up a little bit here. Okay, so what I did in this case, I don't have the periapical radiograph here to show you, but I could not see any periapical radiolucency. The only problem was here, and I could see that there was a perforation. So I did not do the retreatment. It was unnecessary because root canal treatment was okay, and I didn't have any periapical problem. What I did, I just created an access cavity, cleaned the perforation area completely, and repaired it with biodentin. This is after 4 weeks. As you can see, the intraoral fistula is gone. The patient was very happy, and this was the 12 months follow-up. That you can see that bone formation has taken place. You can't see it here because the thick and the radio opacity of biodentin is very similar to dentin. And this was a nice case. So I'm just going to play you this video, which tells you everything about it.
This was a male patient in his early 40s who had developed irreversible pulpitis symptoms on his upper left 7 following a full crown placement. The GTP had access through the crown and performed root canal treatment. The patient has been experiencing discomfort ever since, and it had not settled after a few months. He was referred to me for further investigation. On X-ray examination, the root canal treatment looked decent, except potentially a missing MP2. In intraoral examination, there was no tenderness to pulpation, no local swelling, and no sinus tract. 6-point perio charting was between 1 to 1.5 millimeters. However, the tooth was very sensitive to percussion, and patient described it as sharp pain on percussion. I took another X-ray with horizontal tube shift. That didn't provide any further data. At this stage, I decided to take a CBCT. The results were quite interesting. The CBCT revealed that the palatal canal had been missed and the perforation in the floor of the pulp chamber had been prepped and obturated instead. And as you can see, MB2 was also missed. This was explained to the patient and the questionable prognosis discussed. The patient wanted to save the tooth. I removed the crown and removed the GP from MB and DB canals, but not from the perforation site at this stage. MB2 and palatal canals were also found and prepped. Copious amount of irrigation was done with 3% sodium hypochlorite and sonic activation was performed. The smear layer was removed with 17% EDTA and the canals were washed with sodium hypochlorite again. Canals then were obturated with calcium silicate sealer. At this stage, the GP was removed from the perforation site in one piece using braided technique with 2 headstrom vials. The perforation site then was thoroughly cleansed from the remnants of sealer with ultrasonic. The perforation site was repaired with Biodentine. The cavity was sealed with composite and the crown was cemented back on. On 3 months follow-up, the symptoms had completely disappeared. On 18 months follow-up, there was no symptoms, no signs of periapical infection, no sinus tract, no deep periodontal pocket, and no tenderness to percussion.
So that was a successful case of periodontal perforation repair by Biodentine, and also regenerative endodontic treatment. Obviously, I'm not going to go into the details of regenerative endodontic treatment. I think I'm running a bit late, actually. Just going to show you a few cases. This was actually a 34-year-old male patient that came to dental hospital, and we decided, because it was an open apex, we decided to go with regenerative endodontics. This is the Biodentine layer placed over a thin layer of collagen sponge over the blood clot. And as you can see, in 12 months follow-up, we have a very nice healing and also dentin bridge formation. Another regenerative case was actually done in a retreatment case, a 16-year-old boy. Again, in dental hospital, we removed the GP, we cleaned it, we encouraged the bleeding, and then Biodentine was placed over the blood clot, and this is the 6 months follow-up. The symptoms, the sinus tract is all healed, and you can see that dentinal bridge is forming. The quality of the radiograph is not very good, I'm sorry about that. And then ECR. Okay, so the ECR, I'm just going to go very quickly. So in ECR cases in general, if we want to do, because we can do external repair and we can do internal repair. And external repair, we don't normally use calcium silicate material, including Biodentine, because they create a rough surface, and periodontium does not like a rough surface. We need a really highly polished surface, which is usually achieved by composite or glass enamel. However, there are some situations that we can, I mean, that's the best, basically the best material that we can use. You know that the external cervical resorption starts from a point of entry. So there is a point of entry, the resorption starts from that point, and it starts to spread into the dentin in all directions. And sometimes, and usually when it reaches the pulp, there is a PRRS, which is the pericannular resorption resistance sheath, usually stops there and it doesn't involve the pulp. So we have a majority of cases with ECR that the pulp is actually healthy because of this sheath. So this was a case that I saw some time ago, and the patient had this problem, the cervical resorption. I'm going to show you the yeah. So as you can see, it was the external resorption, even maybe with a little bit of pulp exposure, but the tooth was completely asymptomatic and was responsive to the sensibility test normally. I decided to preserve the pulp because it looked like the pulp was healthy. Let me show you another aspect of the axial, maybe it will be better. So there was a small exposure to the pulp, but it was positive to sensibility testing. What I did, I basically removed, the flap was made, and then the granulation tissue was completely removed, curettage down the cavity. As you can see here. And then, as you can see, there is a pulp exposure, there was bleeding, and just like a vital pulp therapy, I basically achieved the hemostasis with sodium hypochlorite saturated cotton pellets. And then Biodentine was placed in the area, and the area was filled with composite. The flap was sutured back on, and I don't know why, but this nose is coming. This is immediately after the treatment, and this is the 12 months follow-up. The tooth has no symptoms and looks like it's worked, and it preserved the vitality of the pulp. This is a case done by Dr. So that was one use of Biodentine for external cervical resorption. As you could see, the part of the resorption that wasn't contact with periodontium was actually composite, highly polished composite. This case was done by Dr. Karina Patel. It was a really nice case, and I asked her to share with me, and she kindly did that. So look at this tooth. It looks like something is going on here on the lower left 7. On the CBCT scan, you can see that there's resorption. But what is this resorption? Is it an internal resorption? It's actually an external resorption, but with multiple portals of entry. So there was a pulp stone which was removed, and then after that, you could see that there are multiple portals of entry. So external cervical resorption is not always cavitation that you can then to repair externally. Sometimes those portals of entry, can be multiple of them, stay small, and they spread into the inside the tooth. The best way then to repair them is internal repair by Biodentine, which Karina has wonderfully done, and this is the 12 months follow-up. Sorry, 2 years follow-up. Another case that I did, and it's this tooth was actually everybody said that this tooth must be extracted, and I agree. It was a bit of a long shot, and it's a endodontics, and I don't really recommend doing it, but this was a young woman really anxious about losing the tooth and wanted to try everything, so we just went for it. As you can see, it's a massive resorption case. So what I did, I just removed all the granulation tissue, and then when I had this clear area, you know that the resorptive tissue is like really vascular tissue, and you get a profuse bleeding. So after it's completely removed, then you suddenly get a really nice and clean area. And then obviously I could not use I could not do the root canal treatment in this situation, because I had to use the sodium hypochlorite, and it would cause sodium hypochlorite accident, would go into the tissue. So what I did, I just put, obviously cleaned it with saline. I put a GP cone here and then filled the whole thing with Biodentine. Unfortunately, I don't have good clinical pictures here, but I will explain to you that what I did in the next visit, then I removed a little bit. This here, everywhere is for a full-up Biodentine. Here, this is a flowable composite which I use for isolation, because the tooth was not, it was not possible to isolate it very well. So I put a little bit of flowable composite to help with the isolation. You can put Orasil as well. I like flowable composite. It's cleaner, in my opinion. Inside is filled with Biodentine. So then through that Biodentine, because I had that GP, I did the root canal treatment, and after that I raised the flap, and then trimmed the biodentine to the crystal level, because you could see that the part of this resorption was subcrystal, part was supracrystal. In the subcrystal level, you want biodentine, you want calcium silicate material. In supracrystal, you want something more polishable. So here, as you can see, this is the biodentine, which is subcrystal part, and then on top of that, I couldn't achieve really good isolation. So instead of composite, I used glass ionomer, and then on top of that was composite. So it was like a sandwich of biodentine, glass ionomer, and composite. If you look at it, this area, which is subcrystal, is biodentine, this is glass ionomer, and this is composite. This is 1 year follow-up. The tooth is still there. It's okay, I think. I don't know how many years it's going to be there, but at the moment, the patient is happy. Everything seems fine. It might fracture. One of the good things that if we didn't want to go down that route, I would probably just because extraction of the tooth would be a challenge as well. It would fracture. I would probably cut it, keep the root, submerge the root, and then use that crown for RBB. That would be another option. And we can also use it as an obturating material in cases with irregularities inside the canal. C-shaped canals, for example, or very, this one was in dental hospital, and we don't have a follow-up for this case, but it was so nice that I didn't want to put it because I didn't have the follow-up. I just thought that maybe I share it. Hopefully the follow-up will be okay as well. So this case was done by my very talented students, Kenda. So she asked me that what to do, because it's just so strange and it files goes everywhere, and it looks like here it's just a lot of things are going on. So then we decided, because we had the pulp, and then we had kind of like a resorption here. So we decided to fill everything with biodentine after placing some sealer inside the canal. This is the calcium hydroxide, by the way, and this is the final result. As you can see, it's nicely, like everywhere we covered everything, and it's all biodentine all the way to the top. We don't have the follow-up, unfortunately. I hope that when we have, I can somehow, somewhere share it with you. Another case was this internal resorption, which we used it for obturation material. We basically decided, again, another talented student of mine, Z, we decided to do everything with biodentine, as you can see, but we have extrusion of biodentine here, but this is the 6 months follow-up, and you can see that it's healing. So it looks like it's good results. Yes, so I think I ran over time a little bit, but thank you so much for listening. Thank you for your patience for this lengthy, long lecture. This is my Instagram account, if you would like to follow, and I'm always available there. If you have any questions, I can answer that, answer there as soon as I can. And I'm ready to hand it over to you, Jake, for the questions. If you wish, then we can do that.
Lovely. Thank you very much. Thank you, Mitra, for that insightful and thought-provoking presentation. I think what we'll do regarding the questions, just because of the time, is I've got a list of all of the questions that have been asked, and I will put them to Mitra tomorrow, and she can answer them fully and thoroughly, and I will add them to a web page to be included in your email that goes later on. It's also, the webinar is also going to be available to watch again. So hopefully, if we put all the questions in one, then you can all read them, and you can all see the answers, etc. So I think we'll do it that way.
Yeah,
if that's okay with you, Mitra?
Yes, that's absolutely fine. I know that it was a bit lengthy lecture, but I just wanted to show all the cases. But yeah, I'm available. I can answer all those questions, obviously. And again, if there are other questions outside this webinar, my Instagram account is available whenever you want. You can approach me, and hopefully I will answer as soon as I can.
Perfect. Yeah, thank you once again, Mitra, for that excellent presentation. We hope you all found it engaging and informative, and that it will spark further thought and reflection around the use of biodentine as a material in clinical practice. Definitely a lot to take away with you this evening. As I said, if questions remain unanswered, rest assured they'll be addressed and responded to. If you have further questions that you've not had a chance to ask, please reach out to us. We'll be happy to answer. The CPD certificates will be sent out next week, and the webinar replay will also be available soon for anyone who wishes to revisit the session or catch up. And lastly, thank you all for attending.
Thank you so much.
Thank you, guys.
Thank you. And thank you for giving me the opportunity. It was a great experience. Thank you.
Thanks all.
Thank you. Bye now.